So can you load the slide? Yeah, Dr. Archana Sarda is a well-known diabetologist, endocrinologist in the Aurangabad city. She is chairperson at Sarda Center for Diabetes and Self-Care, Aurangabad. She is a consultant diabetologist, founder of UDAN, an NGO for underprivileged children with diabetes, and she has been a member of the National Type 1 Diabetes RSSDI Task Force. So I will invite Dr. Sharda to go ahead with her presentation.
Good evening, and I am so happy to hear. It's always a pleasure to be in Diacon, this time virtually, and hopefully next time it will be definitely physically with my entire team, which we always do, or especially for type 1. So I will begin my talk now, which was the role of technology to unravel the mystery of type 1 diabetes. And I'm very happy because I'll be saving time as Dr. Julia and Dr. Anjali have done 50% of my job with the detailed talk about SMPG and the apps which are available for it, as well as CGMS. So I will not have to focus now on the science of it, but it's very, very important now to focus on the type 1 diabetes aspect. I think most of physicians attending the conference do not actively see many type 1 diabetes children or adults. They are few maybe in number, and there are selective centers, of course, who are giving very credible, very optimum care to most of the type 1 children and adults that they receive. So this mystery of numbers that we see is something I just wanted to sensitize everyone to the actual what happens from the perspective of a caregiver and a user. So we often are not able to see the other side of it. We have been talking about in perspective of type 2 diabetes, where people are more structured, they're adults, there is a space between testing and going to the doctor. It can be once in 3 months, once in whenever required. But when you see the world of type 1 diabetes, where every day of your life is a science experiment, and if anyone who is now taking care of a person with type 1 diabetes will totally understand that and accept that every moment is different, every challenge is different, and so many factors are affecting the blood sugar of a person with type 1 diabetes. So these memes were made by type 1 studios, and I just got them because they so aptly represent the situation. And unless and until we are very familiar with this situation, we are not sensitized to the thought on what a wonderful change technology can make, especially in type 1 diabetes. So every other thing, imagine the day starts with how many decisions? I mean, I have just listed a few, but 24/7 it is decision making. What am I going to eat? When am I going to eat? I mean, we also make that decision, but as a person with type 1 diabetes, it is also appropriate food, appropriate time, when and what activity. So if there is a spontaneous activity, it is not just you get up and go. There's a lot of calculation involved. Then counting the carbs. I mean, these are the kind of calculations which baffle so many people, baffle doctors. But look at the ease with which the people with type 1 diabetes actually do and incorporate them into their day-to-day life. And we expect them to do that, which is pretty tough on maybe 1 day, 2 days, 5 days, forever. Then when to check your blood sugar, how much insulin to take, and all these come together, and then you interpret all. What am I eating? What is my activity? What are my carbs? What are my carb counts? Do I check my sugar again? How much insulin do I? And I'm not even talking about the changes that come with the mood or with lack of sleep or excess of sleep, stress, menstruation, sick day. It's a long list. So this was just to put things in perspective that we are very much dealing with a situation which is different in a person with type 1 diabetes than a person with type 2 diabetes. So all these advances have been there for quite a long time, but technology in the last 10 years has really come out with rapid advances. And what are the core outcomes that have come out? So I'm talking in context of care especially, is improvement in glycemic control. This is ultimately what a treating physician is what we would be looking at. At the same time, we are very, very focused on reducing hypoglycemia, because as we all know, we have been talking about it today, the tighter the control, the more the risk of hypoglycemia. Then reduction of the risk of acute and chronic complications, which is understandable as a result of better glycemic control and reduced hypoglycemia. All this automatically, along with having a gadget to use, not having to break, those are the icing on the cake actually. They have an improvement in quality of life. And as mentioned by Dr. Julia and actually both, was individualization of care is possible. Who needs which technology, how, what often, what is their specific requirement, and hence we can change it. So what are the technological advances which are specific to type 1, which has changed their life, which has really unraveled the mystery? So the most single most important aspect is glucose monitoring. Of course, insulin delivery, glucagon delivery, and all the apps or applications and algorithms that integrate these technologies have made a wonderful change. This is not, there is not enough time or the platform to be able to talk about each in great detail. But my purpose today for the talk was to sensitize the physician audience, especially, that how a type 1 can benefit from these technology, and whoever can have it should be benefited for, should be offered a choice, and what all is available. So the guiding principle, I found this very interesting, was you think like a pancreas, right? So once you start thinking like a pancreas, and technology helps you to think like a pancreas. So glucose meters, very early 1971, the first blood glucose meter was made, and that made SMBG a standard of care. I mean, for us who, I think we can't even begin to imagine what life was like for a person with type 1 diabetes when they used to measure the sugar or put the blood in a test tube, see the copper sulfate, the reagent, and how would this possible and how often could they have done it? But this SMBG became a standard of care after 1971. But the contemporary glucose meters have also come a long way, because as we know, because of the cost, not everyone is on a CGMS. So for type 1 diabetes, the glucose meters have become very small. They come in 5 seconds. The use of 3 to 5 microliter of blood only. They are capable of wireless connections via radio frequency or Bluetooth to insulin pumps or smartphone applications. This was talked about, and yes, most of the glucometers today with Bluetooth can be downloaded when a type 1 family comes in, and you know that children are so, especially teenagers, they like to fudge the results. They would not like to tell the truth. Sometimes they would hide it from their parents because they get scolded. These are the times when you just, anyway, for analysis, it's great, but even for this aspect, when you download it, it's just very simple in a clinic on their visit, or direct connectivity as has been talked about. So Bluetooth devices has really changed the way we can integrate the end systems, because you can connect across different types of monitoring and devices. So it is not specific one, and that is the way we want more and more technology to be. All the applications, there's an app for everything today. So apps can automatically receive values and identify trends and share with clinics in between visits. So this is something that has really made a difference, because, and self-analysis. If you see young people with type 1 diabetes today, or adults with type 1 diabetes today, they would have their own app, and they would not have to feed in. Of course, there are lots of apps where you can feed in the food, you can feed in your exercise, your activity, your everything, all parameters, blood pressure, everything can be fed in, including blood sugar levels. The other apps are connected through Bluetooth to your glucometer, and then they can actually absorb it. There are so many apps where you can take a photograph of food and ask for a carb count. So there are n number of apps available. The purpose here is to really look at it and find something which can coordinate, which integrate with the glucose meter to get the best kind of outcomes. So if you look at the right side, I mean, this is just a meme that I found very interesting. Imagine what life is like. The parents are saying, okay, kids, instead of finding Easter eggs this year, we're going to find all the test strips hiding around the house. So life is like lots of testing, and there's everywhere. So they have and to a time where we have a CGMS. So this is a real game changer amongst all the technology, CGMS, which made the game changer and change the mystery got unraveled of what is happening to a person with type 1 diabetes, sugar. So the first CGMS came in 1999. And since then, of course, the technology has improved, and we have heard today from Dr. Anjali how amazingly we can do this. But a type 1, I would just like to mention that this understanding of glycemic variability becomes absolutely paramount. Because as I just mentioned, you're talking about a small child, a child in pubertal spurts, you're talking about teenagers. Everyone has a flexible lifestyle. They're still in the growing phase. So many factors which are changing their blood sugar, which are not in their own hands. And you cannot give, and one should not give, a very rigid kind of a plan to a growing child. So if we look at people with type 1 diabetes, it just not only gives us a complete understanding of the variability, it also helps us to give flexibility to the person to adapt to that variability and not so that it becomes stable. So examining glucose every 5 to 15 minutes allows to assess trends and patterns, this has been discussed, to assess the percentage of time spent in range. Now we're going to talk about time in range in context to type 1, which is probably the biggest emphasis, which is again a game changer on how we take care of our children with type 1 diabetes. Now the changing levels are very rapid in type 1 diabetes. So anything, a small thing can be a trigger. And if that can be accounted in the real-time CGMS, imagine a child goes to a party. Imagine a person with type 1 diabetes is playing cricket or football, is trekking, has some birthdays there and some. So if that rapidly changing level can be accounted for and a correction given, this gives so much of freedom to a person to live the way they want to be. These CGMS can be used standalone or can be linked to a pump. So if they are linked, and that gives a very interesting algorithm which is used, and again, artificial intelligence is being used to make recommendations. And as a result, there are so many benefits that we are going to see later. So this can provide predictive alerts up to 60 minutes in advance for potential hypoglycemia and hyperglycemic events. Imagine a student in school who's in class, or there's a games period suddenly, or there's an extra exercise, or the class runs longer. And if there is this alarm system, because the child may not remember that it is time to snack, time to do this. So the kind of safety this allows, the kind of predictability that allows, these alarms, alerts, are of most benefit when you see in context to a person with type 1 diabetes. For a little while, let's try walking in those shoes. Imagine we always as physicians feel that there are symptoms, you should take care, you should have a structure. But imagine a person every day not sure if the blood sugar is going low or going high, because sometimes the symptoms fudge up, sometimes it's unpredictable. On a sick day, do you have a high sugar or a low sugar? After exercise, is it high or low? It's not so predictable as we think. And when we walk in these shoes, then we realize what all gets missed. So with SMBG, we have seen these slides with the previous speakers, but these are the missed blood glucose levels. So even if we were doing a very frequent finger stick test, right? So these were the peaks, the lows, and the other time, which would be anyhow missed. As was talked earlier, but I would like to specifically talk about HbA1c, which is still a gold standard, but now we have moving on to time in range, because look at these three different scenarios. The first scenario, HbA1c of 7, which was the goal and average of 154, was actually 40% of the time high, 20% low, and only 40% time in range. The second, 70% of the time it was in range, 25% was high, and 5% was low. And look at the third one where it was completely in range. So all three were HbA1c of 7. So in a person with type 1 diabetes, this becomes all the more prominent because there are so many variables as we have seen. So time in range becomes a very comforting factor, because when I see my children with type 1 diabetes and they say, am I never going to get it like every reading right? And now they know it doesn't have to be every reading. So even with SMBG, one can calculate the time in range, but for that one has to have more than 4 readings per day. But if you look at this time in range, which Anjali mentioned in the previous talk, so if 70% of more are in range, it is comforting that they will not get complications and the targets are clear. So minimizing things below 180 trying to make it less than 4% below 70 and maximizing between 70 and 180 is a target. With CGMS, it becomes so obvious. So even if we can't do maybe a continuous monitoring for therapeutic care, then maybe a diagnostic CGMS once in a while, which is cost friendly, pocket friendly, just to know your trends and set your doses and set your patterns. So there are proven benefits of CGMS. There is improved control in type 1 diabetes, decreased time spent in hypoglycemia or hyperglycemia, which is very often missed in type 1 diabetes. And if you're doing just SMBG, there's a decreased risk of complication as a result. Substantial improvement in higher baselines HbA1c specifically is seen, and substantial improvement in those with frequent sensor use. So I also see this in my clinic when we see patients who do diagnostic CGMS, even they benefit because they are able to set their doses. They come to know of nocturnal hypoglycemias, what happens in school, what happens with the evening snack, which is otherwise missed, even if you're doing an 8-point SMBG. But the ones who are on a continuous CGMS as a therapeutic tool, they are doing so much better because real-time monitoring can really change the way they take care of themselves. So coming from the technology of CGMS and SMBG, which is really the main mystery unraveler, I would say. Very quickly, I will just go through it. It's not possible because I think there's another session tomorrow as well on this. And insulin pump is a vast topic. Just suffice to say that it is one of the most advanced technology wonders. So most of the people I used to meet earlier used to say it's a way you can avoid pricks. And that is exactly what we want to tell everyone. That's not all about it, right? So I know people who have started a patient on pump just because they did not want to take 4 to 5 picks a day, which is not the right reason. Because these are also the people who will then not do carb counting, will not monitor enough, will not integrate the entire information. So insulin pump is way beyond just the pricks. The whole, especially if one can have a continuous glucose sensor and use a control algorithm. So nowadays we have so many kinds of pumps. The first one came in 1974, which was too large, but commercial pump came in 1980. So it's like been a long time. And in 4 decades, it has shown amazing improvement. Studies have shown benefits of improved control, less variability, decreased hypoglycemia, improved quality of life. We all know that today there are pumps, which are sensor augmented pumps. You have alarms for lows. You have a pre-alarm. It can suspend before it can go into a low. So imagine a small child, imagine a teenager who is out very active. Imagine somebody who has brittle diabetes, even a pregnant lady with type 1 diabetes. These are people who absolutely benefit from an insulin pump. There are so many types of pumps. I'm not going into that, but I think it's very, very important that every physician knows that this is an option. We often think money is a limitation, but we'll be surprised on how many people would somehow manage to spend for something like this, which improves their quality of life. It is absolutely not that simple. So if you see a person doing bolusing themselves on a pump or using a CGMS, the calculation is no less than really quantum physics and string theory. So just calculations, you have to know your insulin sensitivity factor, you calculate your own carb counting, and then decide your bolus, whether it's a correction bolus. So all this becomes easier when we have lots of applications and algorithms. So when we try to work on these, there are so many. There are some Indian ones, they're across the world. So whichever app we use, whichever algorithm a particular machine system uses, but it's very, I feel my purpose here was to sensitize that these are available. And as per our requirement, are we looking at something which also takes into our diet, exercise, and other parameters? Are we looking at something that just gives us graphs and tells us our trends? Are we looking at something which is real time? So whichever we feel is good for us, just logging, but there are lots of apps and algorithms available which can make such string theories simpler for us, give us a direction, and help us to bolus correctly in the type 1 diabetes. So at the end of it, I think if we look at this whole scenario of technology, which sometimes is overwhelming, but if you look at it from a perspective from the caregiver. Imagine a parent who says, when there is this cupcake, the blood glucose is 114, the carbs are 45, bolus 1.3, and he knows or she knows that my child is alive and can eat this. There is no value, no amount of money value, monetary value that we can attach to it. It is a priceless feeling to be able to give this kind of uh, freedom to our child to live to their full potential. So technology overall has really come a long way in giving a better quality of life, freedom, growth, outcomes. And if we have to step into those shoes to realize what a huge impact beyond medical care it makes in a life of a person with type 1 diabetes. Another thing which I just wanted to mention is also the glucagon preparations for type 1 diabetes, which are very important. Earlier, we did not have them. Now these are US FDA approved. There's a hypo pen as well as nasal glucagon. So that's another part which is absolutely important for type 1 diabetes. So I would like to conclude by saying that technology has definitely given us insights and tools like never before to provide optimum care to a person with diabetes. And this care we experience every day. I deal a lot with rural type 1 children, and my children in their fields, when they get up in the 4 a.m., they are farming, they're walking to school, but having a CGMS gives us insights, and we are able to then plan their insulin, their monitoring, interpretation, nutrition, everything accordingly. So whether it's urban or rural, it makes a huge difference. But individualization of which technology will benefit whom is very essential. It is not just based on the monetary aspect. It is also based on what is needed, what is the problem area, and is it going to benefit. But whatever we do, motivation and education remain the cornerstones of type 1 diabetes care with or without technology. Even with technology, unless a person is highly motivated and is willing to be educated in the right way of integrating the knowledge of carb counting, of insulin pump and CGMS, and doing it in a motivated manner. Because without this, that technology will become redundant. So with this, I conclude, and I totally appreciate the efforts of especially Dr. Bansi Sabu in making a difference in the type 1 space in our country through RSSDI, through various platforms. This is a picture of the first One Up challenge, which went to Kalsubai, 23 students with type 1 diabetes from all over the country. Almost 30% distribution were there. Some were on basal bolus without any technology, SMBG. Some were on CGMS, and some were on pump and CGMS, but all did very well. Education and motivation was what made the difference. And of course, when we studied, it was much easier for the ones who were using CGMS and the pump. Thank you very much.